Good afternoon, everybody. We are back. إن شاء الله ربنا يتقبل صلاتكم وطاعتكم ورمضان كريم إن شاء الله، وإن شاء الله يكون شهر مبارك عليكم. Welcome back, and we welcome the new speakers. I can see Dr. Junaid now. Welcome back, my friend.
Thank you, Dr. Ahmed. Thank you for remembering me.
Dr. Mohamed Sulaiman, the big boss, how are you? And I can see also Ausra. Ausra, welcome. Very good. Just to wrap up, for the newcomers, we have closed the first session. I'm very proud of the results and conclusion of the first session. It was great. I have many comments, positive, and you have many questions. Discussions was very fruitful and rich. Dr. Aminu Gohri and Dr. Ahmed Yassin. Now, Dr. Ahmed is still here. I'll tell you the agenda now. We will go for four presentations. Dr. Junaid Khan, Dr. Mohamed Sulaiman, and Ausra, and then Dr. Yasir Basha. As stated in the agenda, 30 minutes, better to be less, because what happened last session, we finished the presentation earlier and we gave more floor for discussion, which was very, very fruitful. So I appreciate if the speakers can squeeze the time a bit and give more time for discussion. The attendee has exceeded 900, maybe 1,000 now, and it was great. The contribution and participation was very, very satisfactory. Now, this session will be, the moderator will be Dr. Ahmed Yassin. I appreciate his approval for this, and Dr. Ahmed, you're lucky because you will introduce eminent speakers. I wish if I will introduce them, Sulaiman, Junaid, and okay, I'll give you this privilege and welcome everybody. And Dr. Ahmed, please.
Yeah, you're right, Dr. Ahmed. I don't know, do you hear me?
We do.
Yes, yes.
Yeah, assalamu alaikum. You're right. It is a privilege and honor to introduce a friend and colleague, Dr. Junaid Khan. I'll just give him some introduction about him. He's American board certified in pediatrics and neonatal perinatal medicine.
Okay.
Also concurred American board in medical quality. There are many lines here to talk about him, but I don't think there's time for that. So welcome, Dr. Junaid.
I have a little, the negative impact, unfortunately, is more, and the positive impact also. So there's a lot of webinar also. So can I take my question and answer after my talk? If you have, otherwise you have my email, please send it. And I love to answer all the questions regarding the neonatal COVID thing. I'm sorry about that. I have some other commitment to fulfill, but I guarantee you I will answer all the questions if you send it to me, or if somebody asks me live after my talk. So once again, Dr. Ahmed Hussein, as he mentioned about the pediatric club, it always love to join you in your pediatric club and pediatric conferences. We have a bonding of our friendships since long. So with that, I will say great work, Dr. Ahmed Hussein, and great educational activity and the service you give for the pediatric and neonatology in the Emirates of Abu Dhabi. So now I can share the screen. So So Dr. Ahmed Hussein gave me a task to talk about the neonatal COVID. Very huge task. Within this 20, 30 minutes, when I'm talking, I can guarantee you maybe 3 or 4 articles are also published. So this is an evolving topic, but I will try to give you some idea about what is happening so far. And we will go in a chronological order. Most of the references, of course, is a 1.5-year-old disease. So it's 2020 and 2021. I have nothing to disclose. So the first part of my talk is about COVID-19 in pregnancy, about the transmission, about the neonates, how they impact the neonate, and the second part about the breastfeeding, which is yet another important topic about that. So first of all, what is happening in the COVID in the pregnant woman? So this is the study we just published in the New England Journal of Medicine. So the universal screening in New York academic setting, and it during the 2 consecutive weeks in the late March and early April, 215 pregnant women tested at admission for delivery, 15.4% COVID positive, but only 1.9% COVID symptomatic. So the key takeaway with that, risk of underestimating the COVID-19 positivity in women delivering. So we have to be very careful. The data is still not suggesting the correct picture of what's happening with the mothers, which is going to be deliver the baby. They are symptomatic, asymptomatic. But right now, this is around figures, but we have to wait more for more data. Then there's a systemic review. It's about 11,000. It is actually multi-center studies, multi-country studies, and it's published in 2020. Is about 11,000 participants in that study. And that result demonstrates that the maternal characteristic, clinical symptoms, maternal and the neonatal outcome are not worse or different from the general population. So that's actually a point of encouragement a little bit that as a neonatologist or as a obstetrician, that these patients are not more sicker than the general population because of the pregnancy. So this is like some we give us a confidence when treating with these type of ladies. Pregnant women are affected by the respiratory complications of COVID-19 in comparable way to the outcome described in the general population. So it is almost the same. So the COVID-19 knots look being more aggressive during the pregnancy, and this is the best sentence, and the perinatal outcome might depend on the T helper 1 and T helper 2 balance. After that, we have to see is the COVID-19 a problem during the pregnancy or delivery? So in 2020, we don't know the answer. The overall answer at that time, we don't know that it is really a problem during the pregnancy or the delivery. It can change the outcome of the deliveries. So at that point, we don't know. But the 2 questions they answer. Can COVID-19 be passed from pregnant woman to the fetus or the newborn? So at that point, it is a very controversial thing. I'm talking about 2020. So no confirmed maternal neonatal vertical transmission that at that time, still don't know if the pregnant woman with COVID-19 can pass the virus. No infant born to the mother with COVID-19 has tested positive for the COVID-19 virus. The caution, they said that the recent information at that time, it's 2 possible cases confirmed vertical transmission are being published in Canada and France. So that's how is the situation at 2020. The second question in the 2020 is, if a pregnant woman has COVID-19 during pregnancy, will it hurt the baby? So at that time also they don't know. I will give you in my, after this, how it affects the neonate. So we do not know at that time that it is really hurting the babies or the babies has a different outcome as compared to the babies who are not delivered to the COVID positive mothers. So the question arises that how the mother can transmit this disease. There are three possible things as any other disease. Intrauterine transmission through placental hematogenous spread of virus, intrapartum transmission through the vaginal canal after exposure to maternal infected secretion of feces around the birth time, and the postpartum transmission when the mother can hold the baby and can transmit by the air droplets and respiratory or by any other thing. So the main thing is the same, that these three possible transmission, they figure it out. The other thing they want to look at into the SARS-CoV in human milk just as a contamination, or it can be really transmitted. So this is the second part of my talk. I will talk about the breast milk a little bit in a detail. So first question is the mother, how the mother can be transmitted. Is it vertically, or it by postpartum, or is intrapartum? So now the vertical transmission, which is the intrapartum transmission, they figure it out. It can be the biological plausibility, or it can be possible that it can transmit. But no confirmed case up till June 2020 that it is showed that it is transmitted through the vertically to the babies. And there are a few cases, a very small number, the virus was found in the samples of amniotic fluid or the breast milk and in throat swab soon after the birth. So at this point, we know the virus, it can be in the amniotic fluid and the placenta. Virus can be the cord blood, so the neonate and the mother. Virus in the respiratory secretions, and neonatal disease attributed to the COVID-19. So this is the pathway we are looking into it. There are many studies suggesting that there is a possible vertical transmission. So these are the 1, 2, 3, 4, 5 studies suggest that this is a positive transmission from the mother to the baby. But there are many studies say there is no evidence of vertical transmission from the mother to the baby, and it just published in American Journal of Perinatology in 2021. So how it happened? So the first case, it happened in the second part of the 2020 in Paris in France. So 23-year-old mother with a fever and productive curve, delivery curve through the C-section at 35 plus 5 gestational age. And why they delivered at 35 plus 5? Because some pathological fetal heart racing, it may be the bradycardia. Baby is male, 2.5 approximately kilogram. Apgar was 4 to 7. Ventilatory support for 6 hours, then extubated, and then the baby did well. On day 3 of life, neurological symptoms presented with irritability, opistotonic features. MRI showed the bilateral gliosis of the deep white matter periventricularly. CSF repeatedly negative, no cultures positive for any sepsis or any pathogen except the SARS-CoV. Slow recovery with no treatment. At 2-month follow-up, the baby is well and improving. So this is the first case. And as you can see that initially the baby is affected quite a bit, but we don't know because it can be the 35 weekers. This can be only the prematurity, which show the bilateral gliosis and all those things, or it can be the SARS. So we don't know at this point, but is he recovered at 2-month follow-up? The baby is well and improving. So this is a very encouraging that this disease, if it is the cause, then it is not affecting the neonate as that much. How the diagnosis, they could just collect the different sample and see the viral loads. So in nasopharyngeal swab in the mother, vaginal swab, placenta, amniotic fluid, and blood. So the placenta is the highest viral load in that mother. In the neonate, the highest viral load in the day number life of 3 in nasopharyngeal swab, and then is the 18 day of life nasopharyngeal swab. So how they diagnosis. So the final answer, does it exit vertical transmission for COVID or 19? Yes, it can be, but it is presented in the amniotic fluid and neonatal swab. It does not mean the vertical transmission, but the possible theory is it can be transmitted because of from mother to the baby. The DOH guidelines, if the mother's positive, first of all, there's a designated hospital in Emirates of Abu Dhabi, and the DOH guidelines, you can find it on the DOH website. And it clearly mentioned that how to deal with that. And I will give you some guidelines, because the problem is that the internationally guidelines are changing. And with the passage of time, the guidelines, the local guidelines is also changing. So yes, there is some guidelines which we are going to discuss right now, but it can be changed accordingly. So let's say if the woman arrives at the hospital, it should be all the precautions. The doctor should take all the precautions. Women with suspected or COVID-19 should be taken into the negative pressure room. So that's why the negative pressure room is not available in all the facilities. So we have to transfer these mothers to the COVID designated facilities. Women should be tried by the obstetrician, will be responsible for drafting the plan. In labor, then it go directly to the labor ward. If immediate emergency, then of course is deal accordingly. And these are the some test recommended investigations. So mother is suspected, mother came and you take care of the mother. Now come to the baby. We don't know at the 2020 that how exactly that COVID-19 can affect the baby. COVID-19 infected neonate looks mostly asymptomatic. Whatever the few cases at that time, only a minority of the neonates show mild respiratory instability, sepsis-like symptom, but likely attributable to concomitant conditions. So all the babies have some like these symptoms very commonly. So we don't know it is the COVID or the other things. So the coronavirus infection in neonate, a systematic review in the end of the 2020 is published. The most recent was updated review on the neonatal COVID-19. It's no significant change from what is stated in March 2020. So up till December 2020, from the March 2020, there is no significant change in the presentation of the COVID. So what they think, there's a multi-country and multi-system study, China, Spain, Iran, and France, all those countries which has a very high COVID rate, Belgium, Germany, and of course China, and the demographic, they took it and they found the sign and symptom. But the end result is that it's a limited burden, limited severity, few cases series so far described at December 2020, mainly China, Italy, Brazil, Iran. You know that these countries are very, very high rate of mortality and infectivity in the first wave of the COVID. Many of these are asymptomatic, room airs for 75%, some 30% have only mild respiratory distress of those newborns. So the implications for the practice in the newborn include, so how you deal with that. So the mother came, you take care of the mother, now you have to take care of the baby. So there are different things you have to do. So initially, what happened that they potentially the NICU organization changes, the social distances, don't do the clinical round, just limited staff, key concern to the personal protective, difficult try the decision, physical and mental exhaustion, and all those is there. Then potentially family-centered care changes, the no breastfeeding, skin-to-skin contact, no skin-to-skin, and no parent involvement, and all those. But it has a very negative impact. It changes in the parent-infant bonding, consequences for the rest of the admitted infants and the parents, and many things. So luckily, in the new field of neonatology, we don't face that much. So I will share the guidelines that what we are doing right now. So first of all, approach in the delivery room. Of course, you have to have all your precautions if you know that the mother is COVID or suspected COVID. The most important thing is that it can be transferred from the baby to the healthcare workers by the vapors and by the aerosolization. So you have to be very careful. You have to have a proper N95 mask, the shield, and all that coverings with you. Then how to do the sectioning. If it is non-intubated, you should do the continuous sectioning. If it is ventilated, then you do the closed circuit sectioning CPAP, you can provide it as in any babies. The only change is that the bacterial or the viral filter, you should put it through the machine so it will filter as much as possible. So endotracheal intubation is the most dangerous thing because you have to bend and you have to go near to the baby to provide the endotracheal to do this procedure. So it's you have to be very careful and you cover with yourself with all the protective gears. If you have the video laryngoscope, it is much better because then you can stand up and then you can see in the camera and you can intubate it. So these same strategies we should adopt it with a few suggested modification. As I told you, the filters, the protective gears when you are dealing with those babies, and any strategy in such unit should be tailored according to the individual patients. So the newborn care DOH guidelines said the baby can be cleaned, dried as normal while the cord is still intact. So we have to do the delayed cord clamping. We have to not to be in a hurry to do things. So the delayed cord clamping, we should do it. Or in case of preterm baby, standard thermoregulatory measure, whatever you are doing right now. Skin to skin contact at that point should be discouraged immediately after delivery within the delivery room, as the later is considered an aerosol generating environment, as I told you before. So the risk of skin to skin care at the time of delivery is there. So it should be avoided at that time. So now the mother, you take care of the mother, you take care of the baby, and baby delivered. So that in 2021, what we know that what we know about the neonate with the COVID infection. Of course, we know that this immature immune system in all the babies, especially the premature babies. So the lower ACE2 gene expression, this is the main gene which are effective in the infectivity or increased severity of the disease. So this is a kind of a protective mechanism that the neonates don't have that much high the severe disease. Neonate, however, have been reported, some of the neonate have been reported to more severe illness than the older children. So the lowest severity is in the older children, which is like 3, 5, 6, 7 years old. The COVID positive neonate should be clinically monitored and isolated, and the symptom positive neonate is mostly supportive. Okay, so rest of the things you have to do the same. If you think you have to have a negative pressure room, you wait until the 2 COVID tests come negative, and then you can transfer the baby to the mother. You all heard of the new disease, which is related to the Kawasaki in older children, which we call the multi-system inflammatory syndrome. It also reported in the neonate. So it is a novel condition following the COVID-19, especially in the children, and it is characterized by the fever, elevated inflammatory markers, high levels of both pro and anti-inflammatory cytokines. Neonatal inflammatory, multi-system inflammatory syndrome has rarely been reported. So first one in the literature is 49 days old infant whose family member test is positive when the infant was 2 weeks old. It's presented with severe gastrointestinal manifestation, hypoalbuminemia, severe anemia, elevated D dimers and ferritin thrombocytosis. So similar picture of the Kawasaki, if you or modified Kawasaki in the early phase and subsequent thrombocytopenia. The serum brain natriuretic peptide BUN was elevated, and echocardiography showed mitral regurgitation but normal coronary arteries. The infant was treated with intravenous immunoglobulin, same as like a Kawasaki, and pulse methylprednisolone therapy with subsequent improvement. There's another case which is 33-week gestation with worsening pericardial effusion on ultrasonography in a pregnant woman with positive COVID serology and recent febrile illness. So this infant was treated by dexamethasone in addition to the management of PPHN. He has a PPHN also, and which lead to the complete recovery. So they can have the severe form, but the good thing is that they come out of it, and most of them has recovered completely. Now, I will take the rest of my time breastfeeding and the COVID-19. We are always should be the advocate for breastfeeding. So let's say what the evidence said. So the neonates infant immunity, the first 4 months of life are the most critical, since the only protection derived from the maternal external antibodies. Okay, so the maternal antibodies to be fully provided through a term deliveries, and it takes almost 17 weeks to reach the full. The more antibody received, the higher the protection. Infants who get infected have received less maternal antibodies. Maternal vaccination in pregnancy might be the good option. So we should encourage that. Breastfeeding is currently the best possible option after the birth, and how and why I will tell you now. Take this example. This is the bronchiolitis due to the RSV in the newborn. And as you can see, the probability of hospitalization for bronchiolitis in non-breastfed babies are very high as compared to the breastfed babies. So this is one of the things they take this 2013 study as a hallmark, and then as a benchmark, and then they built their case on that. Not only that, there's a thing called the lactoferrin, which is now they are putting in the standard formula also, which also help in reducing the all types of the infection. So this is also very important to know that the breast milk, not only this lactoferrin, but has many other substances which decrease the infectivity of any kind. So lactoferrin is actually the rationale behind the lactoferrin is iron homeostasis, less pathogen, antioxidative, direct antiviral actions, and more specifically, if you think about the COVID-19, it interacts with the heparin sulfate proteoglycans, which mediate the transport of extracellular virus particles from the low affinity anchoring sites of the cell to the high affinity to a specific entry as the ACE2, as I told you. The ACE2 is the initial or the specific gene which decided the severity of the disease. So it blocked that thing by this mechanism. So it is very effective, and it is present in the breast milk in abundance. So the question arises that is COVID-19 a problem for breastfeeding? Can COVID-19 pass from the lactating mother to the infant through the maternal milk? The current answer is no. So it's just published in 2021, and they found it out that no positive breast milk sample have been reported. They took it in 47, one single case in June 2020 from Germany. The risk for the passage of the virus from the mother to the infant during breastfeeding, if any, therefore associated with close maternal neonate contact rather than the possibility that the virus is through the milk. So it can happen that the baby get the virus from the mother through the coughing and all those signs and symptoms, but not through the milk. Another important study in the Italy, and they found it out, the samples of human milk from 14 breastfeeding mothers, and they did the virology. All 14 underwent a clinical follow-up. In 13 cases, in milk sample result negative. So this is very assuring that we shouldn't stop the breastfeeding at any cost. I will tell you when you can stop it, but then you will do the express breast milk. So the conclusion of these data support the view the SARS-CoV positive mother do not expose their newborns to an additional risk of infection by breastfeeding. Early identification of IgA, we know that in the breast milk, there is an abundance of IgA, which is against the protective against the COVID also. So the 32-year-old pregnant woman, gestational age 37, was admitted with the flu-like syndrome caused by the COVID-19. The female newborn born with the 2.89, and the length is, and the head circumference is normal. The mother is managed, the isolated, but breastfeeding is continue. And what they found it out, that anti-SARS-CoV immunoglobulin A was detected in the 2 samples evaluated at 3 and the 5 ml samples at the day 3 of the life. So it helped in stopping the COVID-19 and protecting the baby against the COVID-19 because they have this anti-immunoglobulin. So these are the guidance for the all the world big associations. So AAP, UNPS, French, Brazilian, and UK. Only the AAP recommend to consider separating the mother. I will tell you in a very some situation. Otherwise, the Italian, Pediatric, Brazilian, and UK Royal College for Pediatric and Child Health all are the same, that recommends not to separate mother, continue the breastfeeding unless a very limited situation. So these are the guidelines. So if the mother is asymptomatic or posse or mild symptoms of, to be COVID-19 positive, if the pharyngeal swab done in the mother, then you should do in the baby. Isolate the station of the mother. Yes, management of the neonate in rooming in, you don't have to separate it. Advice on direct breastfeeding. Yes, preventive measure for mother. So mother should have to have washed their hand. Mother should have to have a mask during the breastfeeding and all those stuff. If the COVID-19 mild symptoms, mother under investigation, if pharyngeal swab done, yes. If you should do the in the baby only if the maternal test is positive. Isolation of the mother, yes, in an isolation and dedicated area, but rooming of the baby is allowed. Continue with breastfeeding, preventive measure for the mother. Of course, we have to follow the SOPs. Let's say the mother is very symptomatic, respiratory infection, fever, cough, secretions, and too sick to take care of the baby. And you did the pharyngeal swab of the mother and it is positive. So you did, you should do in the baby with the maternal test is positive, and then isolate the mother in the dedicated area. Then you should take the baby and isolate the baby in NICU in a negative pressure room, a unit placed in a dedicated and isolated area in the NICU. You shouldn't advise the direct breastfeeding because the mother sickness and because the mother cannot take care of herself. So it's better to avoid the direct breastfeeding, but use of express milk. Okay, give the machine to the mother so he can express the milk, and there is no need for pasteurization of, or anything. Of course, all the SOPs should be followed. So in any case, we should continue with the breast milk. So there is no current compelling evidence suggests that SARS-CoV can be transmitted from the infected mother to her infant via the breast milk. The nutritional, immunological, and developmental benefit of breastfeeding, if permitted by the mother's health, outweigh the potential transmission risk, if it's any, given the infants typically have mild illness. The antiviral they use, and they found it out during the Ebola infection that it can pass or not, but there is no such evidence. So the Academy of the Breastfeeding Medicine does not recommend cessation of breastfeeding other than the maternal very sickness. The last point is I want to make about the family-centered approach, because it's very disturbing to the family. So you have a shared decision making. Try to engage the family in all your decision making, parental bonding. Do not separate the mother and the baby unless and until it's imminent. Communication with the parents, transparency. Just say the clearly things, because it's only 1.5-year-old disease. We don't know. Yes, it is also evolving every day. Care within social and the cultural context, you have to take care according to that. Long-term impact, as I've said, it is only 18, 19, 20 months old disease. We don't know, so that's why we don't allow mother-infant separation, C-section, early cortical avoidance of breastfeeding. We continue with that. Infected mothers with no or mild symptom may possibly remain hypoxemic for a variable period of a time. The more important thing, which a lot of research is going on, that chronic airway inflammation could result in airway remodeling and thickening, predisposing neonates through childhood asthma, because they can carry this virus in their airways for a longer period of a time. Long-term follow-up of exposed neonates to assess the respiratory, cardiovascular, and neurodevelopment outcome is eminent, and it is warranted. So to summarize it, the COVID-19 epidemic is an unprecedented challenge for all healthcare workers. Pediatrician and neonatologists need to know that children, infant, and neonates may be affected, but usually with less severity. All children may be carriers of the virus. GI symptoms and fecal-oral transmission are frequent in children at all ages. Vertical transmission might occur only occasionally. Neonates can be asymptomatic or experience mild to moderate form of the disease, and most of the time they are recover fully. Breastfeeding is not contraindicated, so you continue with that. The advent of vaccines in the present scenario has offered a ray of hope. Effects of vaccination on viral transmission still remain unknown. If a large enough population to be immunized by the vaccine, transmission may be reduced because of a decrease in symptomatic COVID-19. So we are recommended that all possible you can get the vaccination. Vaccinated individual could be asymptomatic carriers. It remain be seen if asymptomatic viral carry will be affected by widespread vaccination, though it is plausible that this will also be decreased. So the vaccination in all age groups are now important. 18 and above or 16 and above also can be vaccinated. But still, however, in the absence of strict masking, hand washing, and social distancing, viral transmission may continue in spite of the vaccination. So please follow your SOPs. Thanks a lot. If I take a little bit of our time, so sorry about that.
Thank you very much, Professor. Thank you very much for the nice talk. I think because of the time, we'll go further to my friend and colleague, Dr. Mohamed Sulaiman. I don't think he needs introduction. He's a consultant pediatric cardiologist, director of Kids Heart Medical Center, assistant professor of pediatrics, Columbia University College of Physicians and Surgeons, New York, the States, and a long biography. I don't think we have time for that. Dr. Mohamed Sulaiman, I think, is known for most of us. So welcome, Dr. Mohamed Sulaiman, and the floor is yours.
Thank you, Dr. Imad. I really appreciate your nice introduction. And thank you to Dr. Ahmed, who always surprises us with a beautiful conference. We do miss his real face-to-face conference, but hopefully this webinar will do the job, and hopefully we'll meet each other in a near future. So first of all, it's very hard to talk after Dr. Khan, as he's really an amazing talker, and I always enjoy his lecture. So basically, we'll talk about MIS-C, which is a new name. Just a few months back, we didn't have this name. Now we talk about MIS-C, impact on children. We're going to look at how to look at it and how to diagnose and how to interact with the patient. So first of all, I will call it, because of the link related to Kawasaki, I'll call it the typical of atypical of atypical, or new disease that we have to deal with. Okay, so what is COVID to start with? COVID-19 is severe acute respiratory distress syndrome, coronavirus COVID-V2. So we all know about the COVID. We hear about it every single day almost. So the first confirmed case of COVID in United Arab Emirates was in January 29, 2020. And as we know, it started all in China, and then it got spread throughout the world. This is one of my colleagues, Allah yarhamah, Dr. Bassam Berniya. He was a great adult nephrologist who I work with for the last 4 or 5 years. And he basically passed away because of the effect of COVID. So I just want to say goodbye to him, and inshallah, he will be in heaven. Just to go quick to COVID-19 data, the cases in the world, as you see here, the first time I did this lecture was in December 2020, and just see how many changes in 4 months, just less than 4 months, how many changes on the numbers between the first line and the second line. So the cases at that time was 79 million. Now we are talking about 133 million. The death was 1.7, and now we are nearing 3 million. Cases in UAE was now 194, and now we are almost 500,000. Death in UAE was 639, and now as of today, 1523 in UAE. And this is just to look at how many tests we do average per day, which is a huge number that we are doing in UAE. So total vaccinated in the whole world, almost nearing 700 million. in UAE, we are almost about 9 million vaccinated. So I expect that we already either around half of the population or more than half have been vaccinated in UAE in a very short time. And that's a huge, huge achievement for all of us. This is just one of the slides that was sent to us recently about the cities, the safest cities in the world. And we are proud to have Abu Dhabi on the top of the whole cities, major cities in the world, as the safest city for COVID-19. So what is COVID-19 manifestation in adult? You know, simple thing that when we were gonna go to pediatric, common symptoms, you know, just like URI symptoms, fever, dry cough, flu-like symptoms. Then you go to the severe cases when you get dyspnea, chest pain, hemoptysis, crackles, respiratory insufficiency, and so on. And then you go to the complication in the other side, which you get a pneumonia, respiratory distress syndrome, cardiac injury, arrhythmia, septic shock, liver dysfunction, and so on and so on, until you end up with the multi-organ failure, and basically you get so many deaths from it. So the pandemic, you know, the whole world has been affected. Too many publication and research. Still many questions need to be answered until today. And I will just give you what we have here about PubMed. This is I looked at it about 4 months ago, how many COVID publication we have. And that was in 2020. We have 84,000 plus of publication about COVID in a few months. And as of today, we just, you can see, we added about 40,000 or so in about 4 months. So imagine how the amount of publication that happen every day because of COVID-19. Just to compare, imagine congenital heart disease, as of December 2020, we have 174,000 publication, and that's in 100 years. So we soon gonna reach what we achieved in 100 years, and we only added about 2,000 for the last 4 months. In MIS-C, we have 195 publication in 2020 in December, and currently we have about 337. I definitely did not read them. Maybe I read a few. So this is a case scenario of one of our patient, real patient. So he was 15 months old boy, come with a prolonged fever for 3-week manifestation of Kawasaki. He was treated as Kawasaki, and he was given IVIG, and subsequently responded. I initially did not respond, but after that given another IVIG, and he responded well. And then he was sent, he was sent home without any specific diagnosis related to his coronaries. And then he came back, and he was, because of fever again, and then he was looked at to have, thought to have a MIS-C. And then from the mother history and the father history, they both have COVID-19. So just to give you the picture of this patient, this is what we have in normal situation in the coronary artery. This is the left main coronary artery, and this is the right coronary artery. You see how small they are, usually about 2 to 3 millimeter in children or so, according to the age. And you can appreciate there is not much, change in this picture. When you compare it to the next picture, this is our patient. This is an echo. This is an aorta, and this is the right coronary artery, and this is the left. This is initial echo for that patient, the one that we are talking about. They thought this is a major artery, and they did not think this is an aneurysm for this patient. Now, they were looking at this here, in this area here, and it was missed even during the CT, the initial CT. And this is basically the left coronary artery, the LAD, the descending coronary artery, and it has a major, huge coronary aneurysm. This is the coronary aneurysm, probably the biggest I ever seen for this patient who has about 3 centimeter length for the aneurysm, and about 1.6 on the width. You can see it in here. And this patient has a very, very huge, massive aneurysm. I just saw this patient last week, and I did another CT, with a little regression for this coronary aneurysm. So what is MIS-C? You know, in January 2020, for the 4 months after the founding of about the COVID and the spreading of the COVID, 4 months going and no one ever mentioned there is MIS-C or something new. It took us 4 months to we realize that children, they get affected by COVID and they have a different way of manifesting their illness. So it took us until mid-April when we initially the multisystemic inflammatory syndrome in children was described in UK and then subsequently in New York City and so on. This syndrome is Kawasaki-like and it was linked to COVID-19. So just to look at the COVID-19 viral structure, so it's a single-stranded RNA and bind to the host or to the cell by angiotensin converting enzyme A2 in the lung. And this is the main protein in the virus. We call it spike S protein. So this is how the virus enter to the human cells. Basically, this is the mechanism for it. I don't think we need to talk about it, but basically through the S protein attached to the receptors, and then from the receptor go inside the cell and then start replicating itself in millions. So in UK, it was reported initially in 27/4/2020. In London, guidelines was sent to put patient in ICU if you suspect cases, followed by more cases in New York and in USA and other countries. So you can look at these slides that was taken from some other publication from the internet. And this is how we look at MIS-C when it enter the cells. So MIS-C, first of all, is not really the virus effect. And that's what we need to understand. It's not the virus effect directly on the patient. Rather, it is the immune response to the COVID-19 virus. So you get the early stage here of the infection, and you get the SARS, go to, through the macrophage activation, you get helper T cells and other inflammatory response. You get interleukin in here, and you get here a production of antibody. And as you see here, you get a lot of stimulation of macrophage and other factors. And then you get in this area, here is where the problem started, where you get hyperimmune response. And then you get all of this manifestation as a response to what's happening in the immune system. So it's not directly the virus, and it could manifest itself 2 or 3 or 4 weeks after the initial diagnosis of COVID for a specific person. So this is just looking, a lot of time we get mixed up. So whenever we diagnose COVID in children, we think about them as MIS-C. There is difference between the MIS-C as an illness, specific illness, and the COVID-19 illness in children. COVID-19 illness is just like same thing, like an adult. And usually it has a specific soft, mild disease. And as you see here, the response to it, where you see here the interleukin-6 chemokines, and it is not very high for this patient. And there is other factors here, the other inflammatory response, and the viral load for this patient usually milder. So there is not a lot of viral load, or at least that's what we think. And then you get early inflammatory, rapid clearance, and you get mild disease. The patient go home, no problem. So this is the mild COVID-19 illness in children and in adults in similar manner, and in the milder phase. Now, when we are talking about MIS-C, you can see we have far higher viral load, and you have much more inflammatory response and chemical response. And then you get delayed response, you get slow viral illness clearance, and you get more inflammation. And this when you get your severe disease, including MIS-C. So you say MIS-C, this is a slide a little bit old from December 4th. And at that time, we have 1,288 patients of total number of patients who diagnosed with MIS-C. And there was only 23 deaths, which is about 2%. So the death in general is not a very, very common in children with MIS-C. The morbidity is still a major important factor. In this slide, looking at about 100 patients or so, looking at age group, which one most likely to get MIS-C. As you know, for Kawasaki, as an example, we get it more in less than 5 years. However, in MIS-C, most of the patient was between 6 and 12. It could happen before that, as Dr. Khan mentioned, if in a newborn baby, in an infant, in 49 days, and so on. But again, the younger you are, the less likely that you will have a full manifestation of COVID. And I don't know if that's related to immune response or anything. As you get teenager, you still get MIS-C, but it's a little bit less. So the most important age group is between 6 and 12 years old. So in UAE, we have a report from Gulf News stated, I believe it was in May or so, that it was stated that there is no MIS-C patient in UAE. However, subsequently cases was reported and some of them was published. Officially, 5 cases was in UAE published from SKMC, and 1 from Qasmi Hospital, 1 from Tawam, and currently we have another 2 cases. One of them is the one that I showed you right now about patient with severe complication from MIS-C. This is just to show you the publication from UAE. So where is the link? Kawasaki against MIS-C. As you see here, Kawasaki, you all understand it, fever more than 5 days. And if you have that, then you go to the other 5 criteria. You need only 4 of them to establish the standard or the typical Kawasaki disease, the mouth as you see, the eyes, the skin, the legs, and so on. So what's the difference here? You still get changes in the skin for COVID-19. You still get in the mouth. You still can get in the tongue. You can still get almost all the criteria that you have in Kawasaki disease in MIS-C. So what's the difference? If it's there is other thing in MIS-C more than just what we see in Kawasaki. Only about 40% of patients with MIS-C will manifest of themselves as typical Kawasaki or a picture of Kawasaki disease. The other 50 or 60%, they will not have the full manifestation of MIS-C. So here you see it in comparing the COVID or MIS-C in the patient. All the red line related to what we see usually in Kawasaki. So you see the eyes, you see the crackles of the lips. I'm sorry. You see the cervical changes, you see the skin manifestation. Now you get some other thing. As you see it here, you get neurologic signs and you get respiratory signs. So this matter, about 1/3 of the patient will get neurologic changes and respiratory changes, about 34. So the cough and the pneumonia and so on is less likely to be associated with MIS-C as we see in COVID-19. And then you get the cardiac manifestation. Cardiac manifestation, almost 100% of patients with suspected MIS-C will have some form of cardiac manifestation. 68, which is about 2/3, might develop a form of shock. About 20, on this study, at least 28% went to ECMO, which we don't really, I don't know if this is accurate or full accurate or not. Coronary dilation in about 17% and pericarditis about 8%. This is from a study that was published from USA. So, and then the other problem here, as you see in digestive involvement, about 83%. And this is a major thing. Usually this is the main thing where the patient come to the emergency room. And as you see here, a few of them, and I have seen at least 2 patients come into my office who was operated as appendicitis, and they turned to be, this for Dr. Jauhari to elaborate on maybe down the road if he has seen any patient with MIS-C who was diagnosed as appendicitis and subsequently turned to be nothing related to appendicitis. It was all MIS-C. So the GI manifestation in any patient with COVID, with MIS-C will have vomiting, nausea, diarrhea, and so on. This is the big picture, the multi-inflammatory, as you see from the fever point of view, myalgia. This is the other manifestation that we usually see in COVID. Here is what you see from the GI symptoms, vomiting, diarrhea, and increase in AST and ALT, and so on. from the lung, you get hypoxia, pulmonary infiltrate, chest pain. And this is, as you see, this is, as a cardiologist, I'm always biased to look at what's going on in the heart. So you get a picture of myocarditis, you get increase in troponin and proBNP, coronary aneurysm, hypotension, hypoperfusion, and so on. And here you get a lot of inflammatory marker. I think most of you have ordered those markers for your patient when they come. From the neuro, you get the headache and a meningitis-like symptoms and so on. You get also a thrombocytopenia, neutropenia, lymphopenia, and other things. And you got also renal failure. So basically, you get more than one system involved. You get your brain, you get your GI, you get your heart, you get your blood, you get your kidney, and so on. So multi-systemic disease, as the name suggested. So the patient that we see in demographically, when we look at them, most of them will manifest, this is by age from the same study that I showed you earlier. Again, the highest number between 6 and 12. The dermatology manifestation about 80 to 70 to 80%. The older you get less skin manifestation. GI is a common between 70 to 80 or so, and Kawasaki like about 40 to 50%, as you see in this picture, and myocarditis about 50%. Neurology finding it's less likely for smaller children and reach about 1/3 in older children. This is a way how we can look and why the MIS-C is not same like COVID-19. And it doesn't matter if the COVID-19 in adult or pediatric, the COVID-19 manifestation, here you're gonna see it in the dark blue. And this is, you're gonna see it in the other color in here. As you see for MIS-C, the main manifestation is there is asymptomatic. So any patient who has MIS-C has to have symptoms. There is no MIS-C without symptoms. So there is no hiding person or hiding patient that we don't know about who has a MIS-C. They will have to come to you as long as the parents will bring them to the emergency room. While in COVID-19, only about 80% will have some form of symptoms. You see here the fever in MIS-C is the main point, almost 100%. While in COVID-19, only about half of them will have, and that's why the COVID keeps spreading, because the person who have it doesn't even have fever, completely asymptomatic. And you get to the diarrhea here. Diarrhea is a major manifestation for this patient, almost about 70–80%. Vomiting, again, you don't see this in COVID-19. Vomiting, you don't see it much in COVID-19. The rash, you don't see it in COVID-19, but you see it definitely about 60% or even more for patients with MIS-C. The cough, it's a major thing for COVID-19. So if a child have COVID-19, expect him to have cough, while it's very unlikely to have much of cough if he has MIS-C. And then rhinorrhea or URI symptoms, which less likely in both. This is how we look also the difference between COVID-19 and MIS-C. COVID-19 is an early disease. Come, go, finish, bye-bye, by 4 or 5 weeks or so, you are done. While, the patient got infected here at 0 point and start to come to the hospital to see you after about 6 weeks or so. So it's a late manifestation somehow that the patient, due to the immune response, when the patient come and get to you very late. Very unlikely to have a patient with COVID-19 who come to you in a late presentation. So the WHO made a 3 specific criteria to decide what is MIS-C, what is not. So they need you to be less than 21. They raise the age of the children to reach 21. And some of us probably older than 21 still act like children. I'm sorry. Fever, lab evidence. So you get the age, you get fever, you get lab evidence, severe illness, not a mild illness, not a patient come to you to the ER with a little fever and COVID-19 positive. This is not MIS-C. This patient can go home if he has no specific symptoms. And this patient, the one who has severe illness that require hospitalization, this is the one that you can say have multi-system symptoms, at least 2, and no other explanation, and then PCR positive or serology positive, or even though if this not positive, even the exposure could be accepted. As you see, there's about 6 or 7 points for you to diagnose MIS-C. So if you are not sure about your patient, if they have MIS-C or not, just follow the WHO guidelines, and then you will find the criteria to diagnose the MIS-C. Here again, it's here. This one I can send it to you guys in WhatsApp group at later time. So this is all the lab manifestation. I'm not gonna go through it, but definitely, as you see on the slide, almost there is a lot of different lab manifestation, and the sensitivity of the lab at least 50%, 60, 70, and some of them may reach a higher number. So if you accumulate more lab, the more you add, the more you get evidence. So how do we approach the MIS-C when we to say this is MIS-C or not, or so on? You know, you get the fever here, and then you get cough, maybe nasal congestion, sore throat, shortness of breath, all of this, some form of manifestation of COVID-19. Then you test for COVID-19, or you have exposure. Okay, fine. Then, you know, you are directing yourself, is this a COVID-19? You did not start calling it MIS-C yet. And then, you know, when you get the red flag here, you get persistent fever more than 3 days. So it's not as Kawasaki, where we talk about 5 days or more. You can even diagnose MIS-C if in the fever less than 5 days. And then you get a future picture of Kawasaki that will guide you to MIS-C, clinical future of shock, clinical future of heart failure. All of this will guide you. This patient have more than just a typical COVID. And then you get the lab criteria you add here, and then you get a pediatric cardiology referral if you have one of this. And this is one of the big cardio publication who suggested this way to approach and when to refer to pediatric cardiologist if you have any evidence. I will say very, very important, if you suspect MIS-C, please be generous with ordering your echoes. As we mentioned in the beginning, about 100% of this patient with MIS-C will have some cardiac manifestation. So even if the skin is not there, the manifestation of this not there, and you only have fever, you have vomiting, you have diarrhea, you have some other manifestation, you have renal and some lab manifestation, even without skin manifestation, you should order an echo and check with the patient.
2 minutes, Dr. Mohamed.
Okay, so this is just to compare between the two, MIS-C and Kawasaki. Again, I think I'm gonna have to rush the picture to see if there is anything. This is looking at the patient. Who's the patient? You know, what's the end point for this patient? From the same study I mentioned before, only about 2% who died from, but a lot of them got admission to the intensive care unit, about 71%, and at least 60% of them develop a form of shock and need vasoactive agent and so on. So I will just mention quickly the treatment. Similar to Kawasaki, usually there is still a lot of evolving data which one to choose. So usually IVIG, there is a pulse steroid against milder dose of steroid like 2 milligram, 1 to 2 milligram or so. And the aspirin rule, there is here. You can see how you can approach the treatment. I don't really have a time for this. This is looking at the MIS-C and the different manifestation as you see here, and the different way of treatment, IVIG, steroid, and other agent as you see it here, including anticoagulant and inotropes and mechanical support and so on. And there is a typical, you know, recommended investigation according to the severity of the illness, as you see in this one. Again, I don't have to the time to discuss it. This is just comparing IVIG against steroid. Not every person who has MIS-C received steroid, only some of the patient. Now we are having it more a standard of treatment to give steroid. However, in severely ill patient, almost all of them received 60%, 70% would receive steroid. For anticoagulant, so I'll just mention a couple of words about vaccination. Currently, it's not indicated for any patient less than 16 years. and regular vaccination should be encouraged. School regulation mostly as per government instruction. So we currently, we don't advise unless you are 16 years and up. And type of vaccine, I think you are all familiar with this, either mRNA, or we have Sinopharm, which is inactivated vaccine. This is what's going to happen when we vaccinate everyone. So the disease basically will become less prominent, and this is the way that different vaccines they act. And finally, and most importantly, the prevention still the cornerstone from even don't lower your guard, even if you think you already got vaccinated. So take home message, Kawasaki and MSC, different disease, they are not the same. And think about MSC whenever there is other organ involvement. And remember the case definition of MSC as per WHO. And we're still learning a lot about COVID. And personal opinion, vaccinate yourself if you haven't vaccinated yet, and don't worry about the side effect. And make sure you're not gonna fall from Sheikh Khalifa tower.
Thank you, Professor Dr. Mohamed Sulaiman. As usual, very informative, at least for me. It's first time to know there is some MIS-C. We don't know whether we see any MIS-Cs. And this is a very nice lecture. I think we'll go forward. We'll present Miss, I don't know whether I'm going to pronounce it correctly or not, so sorry if I don't. Miss Ausra.
Usra, يعني family.
Okay. And Cirkelyte, is it correct?
Yes, that's right. Ausra Cirkelyte.
Cirkelyte, okay. The pediatric sleep consultant, the founder and CEO of King of Sleep. So yes. Welcome to the floor. And I think most probably we're going to enjoy your talk. Please.
Thank you so much. I hope you're going to enjoy, and I hope you're not going to fall asleep because I'm going to talk about sleep. So I'm sharing my screen. So first of all, welcome. And I wanted to thank for Dr. Ahmed for giving me this opportunity to be here among so many medical professionals. So thank you so much for this opportunity. So first of all, I would like to introduce myself. I'm Ausra Cirkelyte, a certified pediatric sleep consultant. And I work with parents, I help parents who have children who struggle to sleep through the night, who reject sleeping, take long time to fall asleep, struggle with their naps, experience early morning wakings, or even have schedule problems like late bedtime. So today, unfortunately, we are living in sleep-deprived society. As you know, our generation takes sleep for granted, unknowing that sleep is one of the vital biological requirements and not just a luxury. The recent research done in UAE in 2021 has showed that there are 65% of UAE residents who are still not having enough sleep. In addition, a famous scientist and professor of neuroscience and psychology, Matthew Walker, said that the shorter we sleep, the shorter is our life. So today, as we are all met and hit by COVID-19 epidemic, we all experience some kind of damages. So including health problems, including losses, financial losses, depression, anxiety, even the isolation, you know, has forced us to become different individuals and different professionals. So the new norms made new us. First of all, today I would like to introduce you to my pediatric sleep practice, and I would like to share how COVID-19 has affected it. But before I do so, I would like to show, first of all, how children in UAE were struggling during COVID-19. So first of all, children who are at very young age, they had to shift from regular schooling to online learning, which meant that they were forced to use and overuse the technology. In addition, like if you like children as early as from age of 4, they were forced by the schools to use iPads, and they like imagine kids at 4 years of age, they became perfect in drawing and writing on iPad, but they couldn't even hold the pencil properly in their hands. So that, you know, caused a lot of problems for the children. Even restrictions on movement and closure in the schools had severe impact on children's daily routines, their social interactions and activities, mental well-being. According to recent research done, 48% of parents have informed that their children were having poor eating habits, which later resulted in obesity and also created health issues. In addition, most of children experienced those feelings of fear, anxiety, boredom, loneliness, while being isolated. 72% of children had behavioral problems, and even 41% of children experienced sleep problems, which they did not have before pandemic. So now I would like to introduce you to my pediatric sleep consultancy, King of Sleep. And firstly, I would like to share with you my story. So today I am a parent of 2, but when I became a parent first, my son was struggling with sleep. He was falling asleep only while being held in my hands and while being rocked. It was very, very difficult because I was sleepless. I couldn't find solution how to deal with that. And I tried all the things. I tried Googling, I tried asking doctors, and I couldn't find what is this thing, you know, just that magic thing to put him to sleep so he stays asleep. And being a new parent, I've got told by so many people, welcome to being a parent, welcome to parenthood, that's a normal thing, that you will never sleep again. And I felt really sad and depressed because I couldn't function throughout the day. And I couldn't be the parent for my son that I always wanted to be because I was tired. So this is when I decided to go and find the professional help. And I'm so glad, alhamdulillah, I did that because my son started sleeping through the night within 5 days. Once that happened, he became a different child. He became happy. The fussiness disappeared. He started feeding better. He started gaining weight. He became more active. So when I have seen this huge transformation in front of my eyes, I decided that I would love to go and help other children to become great in their sleep. So I became a certified pediatric sleep consultant, and I was certified by Sleep Sense. I also joined, I became a member of Association of International Pediatric Sleep Consultants and of Association of Child Sleep Consultants. And I created King of Sleep in 2018. So King of Sleep provides pediatric sleep consultancy for infants and children in the UAE and globally. And so far we helped around 150 families with 100% success rate, alhamdulillah. We use quick and gentle behavioral sleep solutions that are based on scientifically proven methods. Those methods already have helped 100,000 parents around the world, probably more by today. Yeah, so in addition, King of Sleep teaches parents quite few things. So my priority as a pediatric sleep consultant, the first thing for me is safety. So I really focus to teach parents safe infant sleep practice to prevent SIDS, sudden infant death syndrome. Unfortunately, the statistics in UAE showed that SIDS mortality rate in UAE is higher than in other developed countries. So UAE currently has a mortality rate 0.66 per 1,000 live births, while UK has 0.3 and US has 0.5. So when working with families, I focus to teach them the information so they are able to comply with the safety rules and regulations to eliminate or to reduce the chances of SIDS. And that involves many things like eliminating all loose objects from crib. I always find the pillows and blankets and crib bumpers, toys. I mean, the cribs are always full of things. So families or parents, they have to be aware of that. In addition, parents learn how to establish healthy sleep environments, so how to create healthy nap and bedtime schedules and routines, how to break bad habits, which normally disturb and create those sleep problems, how to lengthen the naps so the child is able to have a long and restorative nap, how to fix early morning wakings and reduce or eliminate nightmares and night terrors. So research shows that it takes the average person 15 to 20 minutes to fall asleep. So what do you do during this time? We all have a way, like the thing that we like to do before we fall asleep, before we enter the stage of sleep. So some of us, they like to turn on one side. Some of us, they like to have a glass of water. So the children require the same opportunity to find what relaxes them and helps them to fall asleep. So it is not what we do for the children, but what they learn to do for themselves. Because if the child has help or assistance to fall asleep, then he will require the same help and assistance to go back to sleep, because he will not know how to do it on his own. Okay. So a sleep association is any action that helps infant to fall asleep, infant or child to fall asleep. And that could be breastfeeding to sleep, bottle feeding to sleep, carrying to sleep, rocking to sleep, or patting to sleep. Once these sleep associations are developed, they become a habit for a child and for a parent. And the longer this habit is being practiced, the longer it will take to break it, and the harder it will be to break it. So the prevention and treatment of unhealthy sleep habits in infants and young children should not be left. It should be solved, because if it's uncorrected, it will persist. There is no such thing as an automatic fix. Children do not simply outgrow it. And research has showed as well that there is a correlation, according to adult sleep specialists, that when they discover adult sleep insomnia in adults, they can find that the same adult had experienced sleep problems at the young age. In addition, treatment of sleep problems is more difficult than prevention, because a parent and the child is already stressed because they are overtired. So it's always better to prevent them than treat them from the very beginning. The basic program of King of Sleep includes 4 steps. So the step 1 is 15 minutes free phone consultation, which can be booked online. During that consultation, I evaluate the sleep problem that the child has. And I also evaluate the commitment of the family if they are ready to start to do the changes that they will have to do. I also suggest them the most suitable program for them. And sometimes 15-minute free consultation is all they need to fix their sleep problem. Sometimes it's just a minor thing. We have to look at the schedule to do some changes with a wake window between the naps, and it will, the child's sleep will improve. The second step is the parent fills out the questionnaire, and I start customizing a sleep plan for the child, considering all the things that they mentioned to me. Once the sleep plan is ready, the sleep plan involves normally the strategies that we are going to use to solve the sleep problem, how we're going to, like the best routine and the best schedule for that particular child that will help parent to solve that particular sleep problem as well. And any questions that they may have from the very beginning, like I would mention there. During 90-minute consultation, I present a sleep plan to the parent and I explain the steps that they will have to do, and I answer all the questions. And the last step is minimum 2 weeks of follow-up support, which is a must in order to succeed. Because sometimes we have to tweak the plan, we have to change once I see how the child is adjusting, how the child is accepting the new changes. Families after completing the program have plenty of benefits. And first of all, let's look at the child when he starts sleeping well. So a well-rested infant or child is a happy child. And young infants can start sleeping through the night as early as from the age of 3 months. Even though I suggest parents to feed the baby at least once at night before the age of 6 months, that child may still drop the night feed on his own before the age of 6 months. Children who start sleeping well, they become less fussy because they are not overtired anymore. In addition, the colic improves. So 85% of families that I get to work with, they inform me that the child, like the very young infant, has colic issues. And what I normally notice is that those babies, they are being fed every time they would cry, and that could mean every hour. Now, when we start teaching the infant to sleep independently without any help, and they start feeding just to satisfy the hunger and not to satisfy the sleep, the colic improves. In addition, every child who sleeps better becomes happier and has strong immune system, which prevents them from sickness and allows them to recover from any sickness or disease if there is. And even it helps them to prevent from chronic diseases. In addition, children who start sleeping well, they have less chances for developmental delays. And I would like to share with you that quite often I hear parents informing me that they've got an infant 6 months old who is unable to roll yet, or 11 months old infant who is unable to sit properly yet without support. So when they start sleeping well, all those things happen. And I had a few months back, infant girl, her name was Myra. She was 11 months who couldn't sit properly. After completing the program, she started walking after a few months, mashallah. So it's amazing that I get to see this transformation in so many families. Now, when the child starts to sleep well, the parent and the whole family has plenty of benefits. So of course, the parent will be happy because his child is sleeping well. The parent can get the sleep back, which the parent lost too because of the child's sleep problem. In addition, the parent becomes confident because they don't need to guess or think, how do I put my little one to sleep? What do I do if he wakes up? The parent has improvement in social life. They can socialize again because they have free time. They can see their friends, they can meet their relatives, which probably they weren't able to do for quite a while. The parents have improvement in their marriage life. So when the child has a sleeping problem, there is quite often the problem between spouses because they are unable to sleep, they are unable to have time for each other, they are unable to communicate with each other properly because there is no patience. They are tired. So the fights start. I've got to work with those families, and it's really sad to experience that or to see that how child sleep problem creates so much problems at home. So when the child starts to sleep well, everything changes. The parents have time for each other, they can bond again, they can spend time with each other, they become patient, and they change their mind to have children again. In addition, working parents, they do much better in their work. So I also worked with parents who unfortunately had to leave their work because of their child sleep problem. And when the child starts to sleep well, those parents, including doctors themselves, they do much better in their work because, they're rested and they can focus better, they become more productive, and they even have more chances to be upgraded. In addition, a good sleep always helps parents to have a better health. And many researchers have showed that once the mother has her proper sleep or she is well rested, she has less chances to experience postpartum depression. Now, those benefits do not come only for the families. So the doctors or pediatricians also refer the patients to me on a regular basis. And once the patients start to sleep well, doctors benefit too, because they have, first of all, happy patients, and because they started sleeping well, they don't need to worry anymore why this child is not sleeping. Because sometimes the child does not need medication, he just needs to tweak some behaviors at home or to change some habits to eliminate some bad habits. In addition, while sleeping patients of doctors have improved colic, and of course, even improved appetite, because the baby who sleeps well is going to be the baby who eats well. As well as patients with strong immune system who are less prone to diseases or to chronic sicknesses, and they can recover faster than others from sicknesses. In addition, less patients with developmental milestones, because sleep helps to prevent any developmental delays. In addition, of course, a doctor can have a better reputation because he has a happy patient, happy parent who has got the solution and the child started sleeping well. So I also have doctors as a customer or as a client. So it's not just that I work with them on referral basis. So I would like to share with you those 3 stories. Dr. Rogando from Bahrain is a mother who was stressed and was facing problems with her family and work because she was not getting enough sleep, and her daughter had struggled with sleep. Her daughter started sleeping through the night within 5 days of the program. Dr. Roa stopped having problems in work and her sleep improved. Her daughter became happy and more active during the day. After a few years, I worked with a second daughter too, who also did amazingly at the end of the program. Dr. Rawan Jamal from Iraq finished working with me this week. Her daughter slept through the night from the second night of the program, mashallah. 8-month-old girl could not feed more than 100 ml of milk at once before the beginning of the program. And I always reassure parents, just wait. After finishing the program, she could have one feed of 200 ml at once of milk. And of course, she's happier, she's having a proper sleep at night, and she's having a great naps that sometimes the mom goes to wake her up because she misses her so much. Dr. Salma Bader from Egypt was struggling to put her son to sleep. It was a difficult case for me myself as a pediatric sleep consultant, as her son had 6 sleep associations and his biological clock was out of rhythm as well. After finishing the program, her son and the whole family got the sleep back. Parents had more time for each other and stopped being late to work as well. Some more doctors, but I will just go fast through that. So Dr. Ola from Saudi Arabia has seen great results after a few days of the program. Dr. Marwa El Said from UK has seen her daughter's sleep improving from the first days and was able to get her sleep and happiness back.
2 minutes, Ms. Ausra.
Okay, so COVID-19 has impacted the way I operate, as 41% of children in the UAE suffered from sleep difficulties that did not exist before the pandemic. More children needed my sleep services or my help. So COVID-19 has brought more families to me. However, many families experienced financial loss as they were losing their jobs or they had lower salaries, so they were not able to pay for the service. So I had to lower the prices. And as well, as most of us, we had to go virtually completely. So in-home consultations in parent home, I stopped completely. And I limited the variety of services that I offer. So I stopped offering premium services, which were assisting the parent in their home half night or full night. So basically, I received more children having sleep problems. And I had more working hours, but at the lower cost. This is my contact information. If you have any questions or you'd like to know more about the programs that I offer, you're always welcome to send me an email. And you can also check out the website and check out my social media. Thank you so much.
Thank you very much, Ms. Ausra. It's very important issue, actually. I would just take the advantage, if possible, to ask whether do you treat also children with autism?
I did not treat it yet. I mean,
regarding the sleep problems.
I did not do it yet. I'm very interested, but I haven't done that. But actually, I have completed the course. I don't know if you heard about it, Doman method course, which teaches how to help children with autism, and not necessarily only with autism, children who have any brain injury. So how to help them overall, not just with sleep. So I learned that, but honestly, I haven't tried myself just to treat children with autism.
Thank you.
I know
Thank you very much.
Probably try, but I haven't.
Very much. Thank you, Dr. Ahmed, for moderating this session.
Thank you.
And I really enjoyed all the presentations. We missed Dr. Junaid. He called me. Now this is the session which should be for the question and answers from the audience, because Dr. Junaid left. Sorry?
Dr. Ahmed, can I just ask a question? I don't want to mess with Ausra.
Okay.
My question was, does she perform any sleep study first?
No, I don't, because I'm not a medical professional.
Okay, that's fine. Okay, thank you.
Yeah.
Okay, Dr. Junaid, because he got an emergency, he has to leave. So I asked him to answer by writing. So he kindly did, and he answered 15 questions. I hope the audience have already got their answer, but still, if you have more questions for Dr. Junaid, you can send him by email. And all the contact info of the speakers will be available with the organizing company, MCO. Now, we'll open the floor for discussion. But before this, I would like to extend my great appreciation first to Dr. Ahmed, who accepted to be the moderator for the session number 2, and for the speakers, Dr. Junaid. Okay, he's always giving us the juice of the neonatal medicine, and Dr. Sulaiman, Mohamed Sulaiman is always see. First of all, he is a knowledgeable, experienced physician, but he's also a successful businessman, mashallah. And every time he come, I like what he always presenting, case scenario. And this is the way we always like to hear. We don't want to go through all the text. It's there on the internet and the books. But when he brings case scenario, it's motivating and interactive, and they let us feel. Actually, I myself, I enjoy listening to these case scenarios. When he said Messi, I thought he's talking about El Barcelona, but there's another Messi. Okay. Let me talk to Ausra also. Ausra, thank you very much for joining us. I came to know Ausra some 3-4 years ago, and I didn't know that time that there is somebody who's treating sleep problems. We as general pediatricians, with all respect to the pediatric subspecialties, but for the audience, all general pediatricians will have this problem in the clinic, because the mother will come and complain. The mother will express her worry during any other complaint. She comes, the child having diarrhea, cough, whatever, then she will tell you that I have a sleep problem. And I was so much impressed when Ausra showed me some of the results. Infants below the age of 4 or 6 months, they go alone and go sleep. That is marvelous. That is very, very successful, in fact. And but the question, do you treat sleep problems in adults as well, or only kids?
No, doctor, not yet.
Okay,
Inshallah,
fine.
in the future.
So we cannot be your client. Okay.
No, doctor.
I invited Ausra. This is for Dr. Ahmed question. I invited Ausra in one of our centers for autism to present her sleep, her experience in sleep problems. And I think that time we asked her the same question as Dr. Ahmed asked. Do you treat kids with autism in terms of sleep? Because the literature confirm, this is the best of my knowledge, maybe Ahmed will confirm. The literature confirm that correcting sleep problems in autistic child will add to his improvement. Okay.
Sure.
That's for sure in the literature, but you did not work with them yet. So I will encourage you strongly to get your courses, get your readings, because you will have a good number of patients with autism, and this will be an added value to the treatment program. Okay.
Yeah.
Now let's go for the Q&A. For my colleagues on the floor, if you want to write a question, please, I would rather appreciate if you write the name of the doctor you want to ask him. Okay, we have a question here for the autism. We finished the session already. Okay. For Ausra, somebody is asking, how many hours can we consider optimal for a child given in a 24-hour period?
For which age?
A toddler of 2 to 4 years.
Okay, so the toddler would require, according to National Sleep Foundation, the toddler at the age 2 years to 4 years would require around 12 to 13 hours of sleep during 24 hours. So I would say that could be 11 to 12 hours of consolidated night sleep and 1 to 2 hours maximum daytime sleep. That would be the optimal.
Okay, thank you. Somebody here is asking about the consultation number because they want to communicate. You can get it always from the website, from the organizing committee or the website.
Yeah.
Yes, that's a very interesting question. How do I know if my child has a sleep disorder?
Oh, thank you for this question, because I think that will be eye-opening for many of you. So I will talk if the child does not have medical issue, because of course, if he has medical concerns, then the answer would be different and I wouldn't be able to answer that. However, if there is a behavioral issue, which normally is 85%, it's a behavior issue. So which means that if you do, or if the child requires anything in order to fall asleep, he has a sleep problem, whether it's feeding to sleep. So breastfeeding is perfect, but if that child falls asleep while being breastfed, it's a problem. Because if you picture yourself falling asleep in your bed and waking up on the street, you will freak out. The same thing will happen with a baby. He will fall asleep while taking a bottle, and then he will wake up in the crib. He doesn't know what is this thing. He will freak out, where is that bottle? So he has to fall asleep on his own in the place that you want him to remain sleeping. And if that does not happen, then definitely there is a sleep problem.
Good, thank you. There is an important question here. I don't know if it is, if you answer it, because somebody is asking about night terrors.
Yeah.
Maybe we can expand the question. Nightmares and night terrors in toddlers.
Yes, I can.
Are you able to handle this?
I can help if there is no medical reason, again, because sometimes they do require medication. If there is some medical issue like sleep apnea, or the children who had a surgery because of sleep apnea. So then there will definitely be another reasons. But toddlers who experience night terror and nightmare. So first of all, night terror and nightmare is different.
Yes.
Night terror happens at the first half of the night, while nightmare happens at the second half of the night. Now, nightmares, when nightmare happens, the child will be able to remember it the next day. However, when the night terror happens, they are not going even to understand what they experienced. They are not going to remember. However, night terrors normally appear when the child is sleep deprived, overtired, or is going through some trauma in the family. So that is very common thing. And to avoid that is, of course, to try to avoid late bedtime, to follow the good schedule for that child, because some parents, unfortunately, they treat the child like an adult. The child will go to bed at the same time when the parent will go. So this what increases the likelihood for night terrors and nightmares. So, just monitoring the awake window that the child gets his 12 hours of sleep, he has his early bedtime, and the science have showed that the best bedtime for young infants is between 6:30 to 8 p.m., which is really happening in the UAE. So, once that child is not becoming sleep deprived or doesn't carry any sleep debt, the likelihood of night terrors and nightmares is going to be reduced. The second thing that's very common with toddlers is it's not the truth. So it's actually, unfortunately, the toddler one day, he would have nightmare. He would come to the mom and he would say, I'm scared, I had a nightmare. However, this wrong reaction of the parent, oh my goodness, come here, you will sleep with me forever. Of course, the child will keep saying, I have nightmare every day. So it's not always the truth that they are having that nightmare every day. It may be true that they had it first time. However, parents were too sensitive, I would say. They showed, too many things that the child would like, and toddlers are going to use that, of course. Then they're going to say it every day, I have a nightmare. So that is very common.
Thank you very much. These kids are more intelligent than we expect.
True.
And the very straightforward example is the, we always see the, okay. This question for Dr. Sulaiman. I don't know, this is a general question. What is the most serious congenital heart defect?
We are going outside the line of the lecture, but
yes.
Yeah, when we talk about the most serious congenital heart disease, if you are at any time talking about hypoplastic left heart syndrome, which basically you don't have left ventricle. So it's not there. So you are using your right ventricle to be your ventricle for life, systemic ventricle, and subsequently all the blood will go, the venous blood will go directly to the lung. So probably that's one of the most important. Then there is other rare disease, like we call it heterotaxy, where you don't know, usually associated with AFib canal, the pulmonary vein is in the wrong place, the artery is coming from the wrong ventricles, and so on. It has its own lecture if we need to talk about that. But usually hypoplastic left heart is a very, very serious congenital heart disease.
There's another question for sleep at different age. The recommended duration of sleep in 7 to 8 years old.
Actually, I've been working with children until the age of 5, but I believe that would be 10 to 11 hours of sleep during 24 hours.
Okay.
For that age. But again, they still need an early bedtime.
Yes,
so the bedtime
question,
like 8 or 9.
Okay. There is a question, I think it was answered in the presentation, but still it's a valid question for as a take-home message at least. The doctor asking, is it important for kids to be sleeping in their own bed or room, and at what age?
Very, very good age. So according to Academy of American Pediatrics, according to SIDS regulations, new regulations, the infant should stay in the same room with the parent to prevent the risk of SIDS. However, the infant has to sleep in his own crib. Co-sleeping should not be happening because it is not safe. I've seen success that normally when the child becomes, when the infant becomes 1 year old and above, and they are sharing the room with a parent, then I would definitely suggest using a room divider or something so the child would not be able to see the parent during the night, because that motivates them to wake up and, you know, just come and take me. So they have to have their own sleep space, private sleep space, which will encourage a better sleep. And very young infants, I would say below 8 months, they can sleep in the same room, and even they can see the parent. But I would say keeping them in the same room from 8 months, I would definitely recommend a room divider, or just moving the crib a little bit further so the infant would not see the dad or the mom during the night. Moving the child out of the room as per safety standards, it's acceptable from 1 year of age, even though some parents choose not to follow it. But then, of course, they have to have the video monitor, because they have to keep monitoring the young child. But I don't suggest doing that, because that's not as per standards. So I would say moving the child out of room from 1 year of age, and they always have to sleep in their own bed.
There's a question here again for sleep. Why many newborns sleep in the daytime and don't sleep during night?
Can you please repeat the question? I couldn't hear.
About the newborn sleeping more during daytime more than during night.
Sometimes the newborns, especially at the very, very young age, during first weeks, they have the confusion, night with day confusion. And the best thing, or the best way to solve it, is just to make sure that they are in front of lots of sunlight during the day. And while they are sleeping, the room is completely dark, just to improve the production of melatonin, sleep hormone. So that helps. But it's very normal thing to see the very young infant at the very first few weeks having day and night confusion, because they just came out from the mom's stomach where it was dark. So it's normal they have that confusion. I can't really answer from medical way why this is happening, but I know that I help to solve this at the very young age by exposing the young infant to sunlight as much as we can during the day, and making sure that he sleeps in a very dark room and away from any blue or green light, especially away from electronics. That's what helps them.
There's a question on the COVID vaccine. I don't know if maybe Dr. Sulaiman or Dr. Ahmed. Why some of the vaccinated for the second dose become positive for COVID-19 after?
I can answer if Dr. Imad. What we are talking about vaccine is it doesn't prevent completely 100% you from getting COVID. So it depends on what kind of vaccine you are talking about. So if you are talking about a vaccine, Pfizer or Moderna, the possibility of getting COVID is about 10% or 5% or so. For Sinopharm, the chance probably about 85% or so in UAE data, and in China probably about 75%. You still have 10-20% will still get the COVID, but almost all the vaccines that will say you are not gonna go to the intensive care unit, even if you become positive with COVID-19. So you're gonna get the milder disease. You may still get positive COVID, but you're not gonna go to the intensive care unit. I hope I answered.
Yeah, but I don't know if the doctor, if the person asking is talking about the illness or the seroconversion, because he said that positive for COVID. Is it positive as a test or positive as a disease?
Yeah, you still can get some symptoms, Dr. Ahmed.
Sorry?
You can still get some symptoms from it, but milder symptoms.
Oh, yeah, that's fine. That's fine. But I mean, you can easily get seroconversion if you have the. Okay. There is a question here for Ausra. Does room temperature affect sleep pattern of a child?
Sure. It's a very
In what
important
way?
So if the sleep temperature is too cold or too hot, the child is going to keep waking up because something is wrong. So what happens at night is the body temperature drops, and automatically, I mean, if the child, for example, infant, is not using sleeping bag, he's using blanket, he will move around, he will kick it off, because many parents still using those blankets, even I try to prevent it. So of course they will freeze, they will wake up because they're cold. If they are too hot, they will keep waking up because they're sweating and they will cry. And very often in my practice, I have noticed that, and I've seen this, that even when we teach the infant to sleep independently and they're sleeping perfectly through the night, sometimes something happened with the air conditioning at home and the parent is not even aware of that because the child is in another room, and like the video monitor did not show that. So the child would keep waking every hour, would put himself back to sleep, and would wake up again. And this is when we really know something is wrong. And then the parent would go check and find that out, and he would adjust the temperature. So it's very important not to overheat them.
I think this answer will also answer the next question. I do in the same principle, because the second question asks about the clothes of the children. So I think regular, normal clothes, not to let him, the child getting warm or cold, will be okay.
I would say the optimum temperature is 21 to 22 degrees Celsius. That's the perfect temperature for them.
Okay, other questions are the same. So, okay, do we have any comment from Dr. Sulaiman or Dr. Ahmed, please? If you want to elaborate on any of your presentation.
From my side, I think, I hope everyone have listened to the talk. I really enjoyed Dr. Ausra presentation. And, it's a great thing. I see how many people are interested to learn about sleep. I think it's a worldwide problem.
Yes.
And I thank Dr. Ahmed personally for his effort in making such a great webinar. Thank you very much.
Thank you very much, Dr. Sulaiman, and all the pleasure having you with us. And everybody, guys, is invited to his conference, because Dr. Sulaiman is now one of the pioneers in conducting conferences.
I would like to add just something that actually may be biased, because I'm a friend of Dr. Ahmed, But actually, I think this is one of the best, symposium or conference, whatever you tell them, I have witnessed in the last few years. It is very engaging, and the collection of the speakers are very important, including myself, and including Ausra and Dr. Mohamed, Dr. Junaid, and Professor Johari. Actually, very nice collection. And also the questions are very, very informative. So I would like to thank Dr. Ahmed Hussein for this opportunity again. Thank you very much.
Thank you very much, Dr. Ahmed. And Ausra, thank you very much. I just received one question now. Postpartum women, when are they going to get vaccinated for COVID? Is it safe for breastfeeding? This should be answered by Dr. Junaid, is it?
Yes.
Okay. So Lady Ivy, the one who's answering asking, send it to Dr. Junaid in his email. Okay. Lastly, but not the least, I'm really very, very happy about the audience, the participants, and I do agree with Dr. Ahmed, although he did not acknowledge the previous conferences. But yes, this conference, the interaction, the participation, the engagement is really impressive. And extending my appreciation to the speakers will never be completed without extending my great appreciation to the participants who gave us the confidence that this conference is adding value to you. Thank you very much for your time and for your support, and we'll see you very soon. Thank you.